Alrighty, so I'm going to be doing my presentation on ARDS and early administration of Aprv and how beneficial it is. So just to kind of talk about ARDS for a little bit. Um, ARDS stands for Acute Respiratory Distress Syndrome. It's an acute onset of hypoxemia and bilateral pulmonary infiltrates following a trigger insult. It originated back during the First and Second World Wars when they were finding that traumatic injuries could cause edematous lung injury, and it was termed shock lung. Only about 5% of mechanically ventilated patients meet the criteria for ARDS, and only about 25% of patients have a mild form, while the remaining are considered moderate or severe. Over the past several years, the incidence of ARDS has dropped, and there are many contributing factors that have caused this drop, some of which are due to major advances in practice, like appropriate resuscitation and antimicrobial administration, restrictive transfusion strategies, and ventilator care bundles and lung protective ventilation. ARDS is really an acute form of diffuse lung injury occurring in patients with predisposing risk factors that meet the following criteria, such as an onset within 1 week of a known clinical insult or new or worsening respiratory symptom, presence of bilateral opacities on chest x-ray, not fully explained by effusion, lobar and lung collapse or nodules, and diagnosis of respiratory failure not fully explained by cardiac failure or fluid overload. And also the presence of hypoxemia, really defined by a specific threshold of a PF ratio that kind of falls into three categories. We have mild, which is a PF ratio under 300, moderate, which would be a PF ratio under 200, and severe, which is a PF ratio under 100. As far as diagnostic evaluation, common risk factors for ARDS are pneumonia, sepsis, gastric content aspiration, trauma, pancreatitis, inhalation injuries, burns, non-cardiogenic shock, drug overdose, acute lung injury following massive transfusions, drowning. I mean, it's a very broad spectrum, and the biggest factor for the best outcome of ARDS is appropriate treatment of the underlying cause, and pneumonia still remains the leading cause of ARDS. Hence, the first step is to quickly identify the pathogen responsible for the infection, and microbiological assessment for any potential pathogens represents the first diagnostic effort. Really, from a pathophysiology standpoint, the main characteristic is increased pulmonary capillary permeability. Accumulation of protein-rich fluid inside the alveoli is a result of the damage to the capillary endothelium and alveolar epithelium. The release of cytokines producing diffuse alveolar damage. The lung is made up of two types of alveolar epithelial cells. Damage to the type 1 cells causes an increase of fluid entry into the alveoli and a decrease of fluid clearance. And then there's damage to type 2 cells, which causes a lower production of surfactant that will of course cause compliance reduction and alveolar collapse. In the lungs of patients with ARDS, several abnormalities have been found that involve gene transcription, pro-inflammatory mediators, moreover, a relationship between the systemic response to endotoxin and the induction of cyclooxygenase 2 gene expression. Characteristically, ARDS has three overlapping phases: an exudative or inflammatory phase, proliferative phase, and fibrotic phase. However, if there is nosocomial pneumonia or ventilator-induced lung injury, also known as VILI, it may complicate this. The initial fluid accumulation is followed within 72 hours by a variable amount of proliferation of type 2 alveolar cells, fibroblasts, and new matrix deposition. Patients who develop fibrosis show a drop in pulmonary compliance, which obviously reduces the gas exchange and increases the mortality rates. Thankfully, based on recent studies, a lung protective ventilatory strategy has been created, which ensures appropriate oxygenation and CO2 clearance, and it minimizes damage from mechanical ventilation, which has been attributed to excessive stress, tidal volume, driving pressure, respiratory rate, and gas flow. Recently, a theory has been made that states that the fundamental causability may be caused by an excessive mechanical power applied to the lungs. So obviously, an inappropriate ventilatory strategy can exacerbate the initial lung injury, both in terms of excessive stress, consequent of the excessive volume of pressure with which the lungs are ventilated, but also as inappropriately low levels of PEEP may cause a repetitive opening and closing of alveoli, which in turn exacerbates the pro-inflammatory response. Now I'm going to kind of go more into the Aprv and mechanical ventilation aspect of regarding ARDS. So we know that improperly mechanically ventilating can amplify early injury and eventually development of ARDS. And full-blown ARDS is refractory to most therapeutic strategies, which have not been able to lower ARDS mortality rates. There's been many suggestions on how to properly ventilate ARDS patients, anywhere from using low tidal volume ventilation. There's also been low tidal volume and PEEP, and there's utilizing Aprv, which is airway pressure release ventilation, with a brief duration of pressure release. Preventing rather than treating ARDS may be the way forward in dealing with all of this, and would represent a big shift in the way that mechanical ventilation is currently used. And according to a lot of research that I've read, it claims that if we appropriately set protective mechanical ventilation to at-risk patients well before any clinical signs of acute lung injury are shown, then our ARDS rates will actually drop. So this picture is kind of just showing like a sequence of events from initial injury to the development of ARDS. Trauma, hemorrhagic shock, sepsis all results in SIRS, which is systemic inflammatory response syndrome, causing early acute lung injury. And as the disease progresses, the patient is intubated and if placed on mechanical ventilation with non-protective breath, or breath mechanical ventilation would greatly exacerbate the lung injury, causing a secondary villi. Thus, SIRS and villi will often work together to drive the acute lung injury, which, if unblocked, will cause ARDS. As far as just kind of current treatments to date, all attempts at pharmacological prevention of ARDS have been ineffective, and the only therapeutic strategies have been shown to significantly reduce mortality are low tidal volume, mechanical ventilation, prone positioning, and neuromuscular blockade. Even so, the mortality from ARDS remains high, greater than 40% actually. And another horrible thing that also happens is that patients who survive ARDS often develop chronic lung and neurologic dysfunction, and then inflammatory mediators produced by villi can injure distant organs, leading to multi-organ dysfunction syndrome that is frequently the ultimate cause of death in patients with ARDS. Since treatment of ARDS is very difficult and the only strategy demonstrated to reduce ARDS mortality is protective mechanical ventilation. So here in this picture, this is just like a pathological tetrad of ALI culminating in ARDS with increased permeability, surfactant deactivation, alveolar edema, and RACE, which stands for repetitive alveolar collapse and expansion. So all contribute to progressive ALI. The diagram depicts an air sac consisting of several individual alveoli, and each alveolus is lined with a liquid hypoase to which pulmonary surfactant is adhered. Increased vascular permeability, fall injury, pulmonary capillaries begin to leak edema fluid into the alveolar lumen, resulting in mild to moderate hypoxia. The surfactant deactivation, when hypoxia becomes sufficiently severe, the patient would be placed on a mechanical ventilation, and if non-protective, would work with the alveolar edema to further damage the surfactant film and increase alveolar flooding. As far as alveolar edema, over time, non-protective ventilation plus the increased capillary permeability will completely destroy the surfactant film, resulting in total alveolar flooding. And then for the race, at a certain level of surfactant disruption, alveoli become unstable, collapsing during expiration and re-expanding during inspiration. And race significantly exacerbates the lung damage by contributing to surfactant deactivation into dynamic microstain-induced increases in permeability, which would significantly exacerbate edema formation. And on top of that, if you have high alveolar surface tension, secondary to surfactant deactivation alone cause edema, combined with increased permeability, would really accelerate alveolar flooding. And once a portion of the lung develops, those key pathological changes establish a little feedback loop, exacerbating, accelerating the progression of lung damage. And if the sequence is really unbroken, then it would cause ARDS. So now, to kind of move on to Aprv a little bit. So people typically think Aprv as a rescue mode to be used only in patients with ARDS who are refractory to any other ventilator strategy. And theoretically, Aprv should reduce villi by maintaining an open lung, resulting in homogeneous lung ventilation. Aprv gradually inflates or nudges the lung open, which minimizes the tissue damage associated with the aggressive recruitment maneuvers. From the research that I've read, it clearly shows Aprv is better than CMV, or controlled mandatory ventilation, for the most severely injured lungs, and is ideal for minimizing ventilator injury cause function. One of the articles that I actually read hypothesized that the mechanism by which Aprv protected the lung was reduced alveolar microstrain. And they found that appropriately set Aprv with an extended duration of plateau pressure, which would be your T high, and a very brief duration of pressure release, which would be your T low, is essential to minimizing the microstrain in the alveoli. In the alveolar ducts, and the microstrain is the change in size and shape of the alveoli and the alveolar ducts in response to a given stress. So both the T high and T low can be adjusted to target a patient's pathophysiology to achieve lung protection via two mechanisms. So the first one being an extended T high progressively recruits and stabilizes alveoli, which results in homogeneous ventilation and elimination of stress concentrations. And two, a very brief T low does not allow enough time for alveolar collapse during exhalation, which minimizes the alveolar microstrain. And then by doing this, there's been a huge drop in ARDS development, and the article proved this by testing the theory on a rat model with villi and in a rat with hemorrhagic shock, ARDS model. And I also read another study that experimented on patients in the ICU setting. They did a systemic review in high-risk trauma patients and demonstrated that preemptive mechanical ventilation with Aprv reduced the progression of ALI. And this analysis compared Aprv applied preemptively with 15 studies using standard care ventilation, applied only after acute lung injury has been developed. And the patients in the Aprv group had a greater mean injury severity score and a lung injury prediction score of those greater than 8, which meant that they had a greater than 30% chance of developing ARDS. But they had a really low incidence of actually getting ARDS at 1.3%, and their in-hospital mortality was only at 3.6%, which kind of tells us that preemptive Aprv can really reduce ARDS incidence in high-risk patients better than standard mechanical ventilation with low tidal volumes and beep. So now for this picture, this is just like a little bit of lung histology that I put here. So at inspiration and expiration determine the microstain caused by mechanical ventilation on the terminal airway. So we define alveoli as individual structures that not connecting the adjacent alveoli. The conducting airways were defined as airways extending from the alveolar ducts proximally connecting multiple alveoli and the remaining structures, including the interstitium, blood vessels, and lymphatics. So the control group was uninjured, showing normal changes in the terminal airway during ventilation. And note that the relative small size of the conducting airways in the open and well-inflated alveoli. In the remaining groups, the ARDS was caused by the twin installation. So 2 settings for the time set at duration at low pressure, T-low, using Aprv and 2 PEEP levels with a tidal volume set at about 6 cc's per kilo, were studied with CMV, conventional mechanical ventilation. So in the Aprv group, with improperly set T-low about 10%, there was a dramatic overdistension of the conducting airways and increased dynamic microstrain with ventilation. CMV with PEEP5 again showed a large dynamic microstrain on conducting airway with more alveolar collapse, and PEEP16 improved alveolar inflation and reduced but did not eliminate conducting airway overdistension. Aprv with properly set T-low at 75% was the closest to control with reduced conducting airway size and microstrain during ventilation and open, well-inflated alveoli. So now for mechanisms as far as how Aprv kind of protects the lung. So there's really 3 mechanisms by which it helps reduce ARDS, and so the first one would be preserving the integrity of the blood-gas barrier, which reduced pulmonary edema formation, thus blocking the sequence of events leading to a surfactant deactivation, alveolar collapse, and subsequent alveolar instability. Second one would be minimizing alveolar collapse with a really brief expiration that occurs during T-low, which limits the time for alveolar derecruitment to occur before the lung is reinflated. And 3, maxing out the recruiting of the lung with extended inspiratory duration T-high, which maintains distal airway or airspace patency and creates a homogeneously ventilated lung so as to minimize stress concentrations in the parenchyma. And these are all, of course, considered lung protective strategies. So here in this picture, so picture A on the top, in vivo, the photomicrographs at inspiration and end expiration of the slow pleural alveoli following the surfactant deactivation between. So to assess the microstrain, individual alveoli were color-coded in yellow with non-alveolar tissue in red, and the alveolar area calculated using the computer imaging analysis at inspiration and expiration. So 2 settings for T-low using Aprv and 2 PEEP levels with a tidal volume of about 6 cc's per kilo were studied with conventional mechanical ventilation. In the Aprv group, with improperly set T-low at about 10%, there was a large microstrain on the alveoli as they recruited and collapsed with each breath. There was also significant microstrain with conventional mechanical ventilation, PEEP5 with less recruitment during inspiration, and then CMV PEEP16 reduced the microstrain but failed to recruit all the alveoli, whereas Aprv, when it was properly set at about T-low of 75%, both recruited and stabilized the alveoli. And then for diagram B, the percent shows the percentage of alveolar airspace occupancy as determined by computer image analysis at inspiration and expiration. So alveolar airspace occupancy was expressed as a percentage of the photomicrograph containing the inflated alveoli at inspiration and expiration. And the larger the difference in the airspace occupancy between inspiration and expiration, the larger the alveolar microstrain. So although the tidal volume delivered to the lung with Aprv is about 75%, is approximately 12 cc's per kilo. The alveolar tidal volume is really small. Is very small as measured by the small measured microstrain. So it's not the size of the tidal volume being delivered to the lung, but the size of the change in the individual alveolar tidal volume that's critical and really preventing vent damage to the pulmonary parenchyma, essentially. And then here's just a couple. Here's just like a little fun picture that I posted. It's a little kind of gross cut photo showing the surface of the lungs 48 hours following the peritoneal sepsis and gut ischemia slash reperfusion that's induced or that caused the ARDS in actually pigs. These are pig lungs. So the lungs from the Aprv group are A and B, and then the low tidal volume group are C and D. The Aprv lung is fully inflated without edema, whereas the low tidal volume lung is atelectatic with significant airway and interlobar edema. Pretty interesting, I thought. And then for one of my last pictures, it's just showing the meta-analysis comparing the standard of care ventilation with preemptive Aprv in patients with significant trauma measured by the mean injury severity score. So a box plot are patients from 16 studies that had roughly 66,000 patients compared with 231 patients preemptively placed on Aprv. And the C identifies the Aprv treated group of patients, and although patients on preemptive Aprv were in the upper quartile of the severity score, A, they were at the absolute minimum for incidence of ARDS, and B is in-house mortality percentage, and C, C is the in-house mortality percentage actually. But to really wrap it up and kind of just briefly go over this entire presentation, overall I just found that the studies supported my theory and my own hands-on experience that Aprv is highly effective in treating established ARDS in patients with serious lung disease, that standard mechanical ventilation is ineffective, and we now have the ability to significantly reduce ARDS incidence in patients at high risk. In all the studies that I read, preemptive Aprv appeared to be superior to CMV at reducing the incidence of ARDS in both animal and human studies. And the essential protective mechanisms of Aprv appears to be related to never letting the lung collapse, which eliminates mechanical damage to the pulmonary tissue caused by stress concentrations arising from alveolar heterogeny and by dynamic alveolar microstrain with alveolar collapse and reopening. And I could just personally say from my own experience, like such as today, this morning, when I was in the ICU, I was dealing with a 17-year-old with progressive ALL. She's, extremely sick, currently on CRT, extremely high oxygen demands. I didn't really get a chance to see her too much last week, but I walked in this morning. First thing I did was calculate her OI. Came in about around 19. She was on standard PRVC, pressure regular volume control, ventilation on the ventilator, and with the FiO2 about 80%, and her PaO2 on her arterial blood gas is about 61. I examined her chest x-ray, which showed very low lung volumes and extreme consolidation. I assessed her work of breathing, which is extremely high, her PF ratio and OI and whatnot. And I just switched her to Aprv, and I kid you not, within 1 hour of her chest x-ray, drastically improved. Her PaO2 went up to about 109, and I was able to drop her FiO2 at 45%. She appeared a lot more comfortable, wasn't nasal flaring, wasn't tracheal tugging. So it truly made a difference. And I was just wish I was able to examine her earlier in the week to suggest this. And she might have not ended up as severe as she is, but who really knows? And but yeah, so overall, I highly recommend it. And if you don't utilize Aprv in your own facilities, then I highly suggest that you start doing it soon. And these are all my references.